Welcome to Medical Specialists Associates Educational Series on topics in critical care medicine. I'm Christopher Voss, MD, MS, FCCP, board certified in anesthesiology, critical care medicine, neurocritical care medicine, and critical care echocardiography. As critical care providers, we are all well versed in the ARDSnet protocol for managing patients with acute respiratory failure. We are also familiar with the option of considering extracorporeal membrane oxygenation for those who are not responding to conventional therapies. But what if extracorporeal membrane oxygenation is not available, and the ARDSnet protocol is failing to stabilize your patient? What options do you have then? In this educational program, we will explore advanced management strategies that you can consider when faced with these challenging scenarios. Our goal is to provide you with actionable insights that could help you save more lives, even in the most difficult cases of refractory respiratory failure. Pathophysiology of refractory respiratory failure. In ARDS, the lungs become inflamed and filled with fluid, leading to severe hypoxemia and reduced lung compliance. When the ARDSnet protocol fails, it often indicates that the severity of lung injury is beyond what conventional ventilation can manage. The persistent hypoxemia and hypercapnia seen in these cases are due to alveolar collapse, caused by surfactant depletion and lung edema, leading to shunt physiology. Ventilator-induced lung injury. High pressures and volumes can exacerbate lung injury, perpetuating the cycle of hypoxemia. Increased dead space ventilation, due to thromboembolic phenomena and microvascular obstruction, reducing effective alveolar ventilation. Advanced management strategies. When the ARDSnet protocol fails, it is critical to explore the following advanced management strategies, tailored for settings without access to extracorporeal membrane oxygenation. 1. Prone positioning. Rationale. Prone positioning redistributes perfusion to better ventilated dorsal lung regions and improves oxygenation by increasing functional residual capacity and reducing shunt. Implementation. Patients are positioned prone for 16 to 20 hours per day. Frequent turning and monitoring are essential to minimize complications such as pressure sores and dislodgement of lines. Evidence. The PROSEVA trial demonstrated a significant reduction in mortality with prone positioning in severe ARDS patients, making it a key strategy when conventional ventilation fails. 2. Neuromuscular blockade. Rationale. Neuromuscular blocking agents reduce patient ventilator dyssynchrony, lower metabolic demand, and minimize ventilator-induced lung injury by preventing spontaneous breaths that can lead to high tidal volumes and pressures. Implementation. Early use of neuromuscular blocking agents, such as cisatracurium for 48 hours in patients with partial pressure of oxygen to fraction of inspired oxygen ratios below 150 has been shown to improve outcomes. Evidence. The Accuracis trial found that neuromuscular blocking agents improved oxygenation and reduced mortality in patients with severe ARDS. 3. Driving pressure management. Rationale. Driving pressure, calculated as plateau pressure minus positive end expiratory pressure, is a critical determinant of lung stress and strain. Lower driving pressures are associated with improved outcomes in ARDS, as they reflect reduced lung distension and decreased risk of ventilator-induced lung injury. Implementation. Adjust ventilator settings to minimize driving pressure, typically aiming for values below 15 centimeters of water. This may involve reducing tidal volume or optimizing positive end expiratory pressure to balance oxygenation and mechanical strain. Evidence. Studies, including those from Amato et al., have shown that driving pressure is a better predictor of mortality in ARDS than tidal volume or plateau pressure alone, emphasizing its importance in ventilation management. 4. Airway pressure release, ventilation. Rationale. Airway pressure release. Ventilation is a mode of mechanical ventilation that provides continuous positive airway pressure with intermittent releases to lower pressures, facilitating ventilation while maintaining lung recruitment. This mode can improve oxygenation and reduce ventilator-induced lung injury by allowing spontaneous breathing and promoting alveolar recruitment. Implementation. Set high and low pressure levels with prolonged high-pressure phases to maximize alveolar recruitment, while allowing short releases for carbon dioxide removal. Careful titration is required to avoid hemodynamic compromise or overdistension. Evidence. Studies suggest that airway pressure release ventilation can improve oxygenation and reduce the need for sedation compared to conventional ventilation in ARDS, though it requires careful management to avoid complications. 5. Esophageal balloon monitoring. Rationale. An esophageal balloon catheter allows for direct measurement of esophageal pressure, which serves as a surrogate for pleural pressure. This enables the calculation of transpulmonary pressure, guiding PEEP and ventilation settings to avoid lung overdistension and prevent further lung injury. Implementation. Esophageal balloon catheters are inserted and inflated to measure esophageal pressure, allowing for real-time adjustments in PEEP and tidal volumes to optimize transpulmonary pressure, targeting values that avoid both overdistension and collapse of alveoli. Evidence. Studies have demonstrated that esophageal pressure-guided ventilation can help tailor ventilation strategies more accurately, potentially improving outcomes in patients with severe ARDS. 6. Extracorporeal carbon dioxide removal. Rationale. Extracorporeal carbon dioxide removal is a less invasive alternative to extracorporeal membrane oxygenation that focuses on removing carbon dioxide, allowing for lower tidal volumes and driving pressures to minimize ventilator-induced lung injury. Implementation. Used in conjunction with ultra-protective ventilation strategies, extracorporeal carbon dioxide removal requires specialized equipment and expertise, but offers an option for carbon dioxide removal without full extracorporeal membrane oxygenation support. Evidence. While still experimental and not widely available, extracorporeal carbon dioxide removal has shown potential in reducing ventilator-induced lung injury in small studies and case series. 7. Ultra-low tidal volume ventilation. Rationale. Ultra-low tidal volume strategies, 3 to 4 milliliters per kilogram predicted body weight, may further reduce ventilator-induced lung injury in severe cases, offering additional lung protection when standard low tidal volume strategies fail. Implementation. This approach requires permissive hypercapnia and advanced monitoring to avoid complications such as severe respiratory acidosis or patient discomfort. Evidence. Emerging data suggest that ultra-low tidal volume strategies may benefit select patients, especially when combined with adjuncts like extracorporeal carbon dioxide removal. 8. High-frequency percussive ventilation. Rationale. High-frequency percussive ventilation combines elements of conventional mechanical ventilation and high-frequency ventilation, delivering small, rapid bursts of gas to promote oxygenation and carbon dioxide clearance while reducing lung injury. Implementation. This method requires specialized ventilators and careful monitoring, but can be useful in patients with severe lung injury, unresponsive to conventional methods. Evidence. Limited data exist, but case reports and small studies have shown potential benefits in severe ARDS, particularly in trauma-related cases. 9. Adjusting positive end expiratory pressure and recruitment maneuvers. Rationale. High positive end expiratory pressure helps to keep alveoli open, reducing shunt and improving oxygenation. Recruitment maneuvers aim to reopen collapsed alveoli, but must be done cautiously to avoid barotrauma. Implementation. Incremental positive. End expiratory pressure adjustments should be guided by the patient's oxygenation response, with an emphasis on minimizing plateau pressures. Recruitment maneuvers, such as sustained inflation or incremental positive end expiratory pressure trials, should be considered, but only in hemodynamically stable patients. Evidence. Studies show mixed results. However, individualized positive end expiratory pressure strategies may improve oxygenation in refractory cases, particularly when combined with prone positioning. 10. Inhaled pulmonary vasodilators. Rationale. Agents such as inhaled nitric oxide or prostacyclin can reduce pulmonary hypertension and improve ventilation perfusion matching by selectively vasodilating well-ventilated lung areas. Implementation. Administered as a rescue therapy, Inhaled nitric oxide or prostacyclin should be started at low doses and titrated based on the patient's response. Continuous monitoring is required due to the risk of systemic hypotension. Evidence. While large trials have not demonstrated a mortality benefit, these agents may provide short-term oxygenation improvement in life-threatening hypoxemia. 11. Conservative fluid management. Rationale. Reducing fluid overload can decrease pulmonary edema, improve lung compliance, and enhance oxygenation. Implementation. Diuretics should be used judiciously to achieve a negative fluid balance, particularly in hemodynamically stable patients. Fluid resuscitation should be guided by dynamic assessments, such as stroke volume variation or passive leg raise tests. Evidence. The FACT-T trial showed that a conservative fluid strategy improved lung function and reduced the duration of mechanical ventilation without increasing the risk of shock. 12. High-frequency oscillatory ventilation. Rationale. High-frequency oscillatory ventilation delivers very small tidal volumes at high frequencies, minimizing ventilator-induced lung injury while maintaining adequate oxygenation through constant lung recruitment. Implementation. High-frequency oscillatory ventilation should be initiated at low mean airway pressures and gradually adjusted based on oxygenation and carbon dioxide clearance. This technique requires expertise and careful monitoring due to the risk of hemodynamic compromise. Evidence. Despite mixed results in trials, high-frequency oscillatory ventilation remains a consideration in selected patients when conventional ventilation strategies fail. 13. Bicarbonate therapy. Rationale. In severe acidosis, pH less than 7.15, bicarbonate administration can help mitigate acidemia, potentially improving hemodynamics and oxygen delivery. Implementation. Administer bicarbonate cautiously, starting with 1 to 2 milliequivalents per kilogram, and titrate based on arterial blood gas results. The goal is to maintain a pH above 7.2 to optimize cellular function without causing alkalosis. Evidence. While not universally recommended, bicarbonate therapy may be beneficial in severe metabolic acidosis where conventional ventilation and fluid management are insufficient. 14. Use of corticosteroids. Rationale. Corticosteroids may help reduce inflammation and fibrosis in late-phase ARDS, potentially improving lung function and reducing ventilator dependency. Implementation. Methylprednisolone can be administered at 1 milligram per kilogram per day, tapering over several weeks based on the patient's response and overall clinical condition. Evidence. The DEXA-ARDS trial showed that dexamethasone reduced mortality and duration of mechanical ventilation in patients with ARDS. Brief mention of ECMO. Extracorporeal membrane oxygenation provides advanced oxygenation and ventilation support by bypassing the lungs, allowing time for lung recovery. However, due to its high resource requirement and limited availability, extracorporeal membrane oxygenation is not an option in many critical care settings. This program focuses on maximizing the use of available resources to manage refractory respiratory failure without extracorporeal membrane oxygenation. Conclusion. Managing refractory respiratory failure when the ARDSnet protocol fails requires a comprehensive, multifaceted approach. By combining prone positioning, neuromuscular blockade, driving pressure management, APRV, esophageal balloon monitoring, individualized positive end expiratory pressure strategies, inhaled vasodilators, conservative fluid management, and advanced ventilation techniques like extracorporeal carbon dioxide removal and high-frequency oscillatory ventilation, healthcare providers can optimize outcomes for critically ill patients, even in settings without access to extracorporeal membrane oxygenation. Ongoing assessment and adjustment of these strategies are crucial for addressing the evolving needs of these complex patients. To learn more about critical care medicine, visit us on our website at www.medspecialists.net and subscribe to our YouTube channel.